Good morning and welcome to today's webinar, Living with MDS, a Clinical and Research Perspective. My name is Linda Thompsett. Working alongside me today are my Leukaemia Foundation colleagues, Jane Anderson and Linda Saunders. Together we will be facilitating today's webinar. Before we commence formal proceedings, the Leukaemia Foundation acknowledges this webinar is being delivered from the lands of the Whadjuk Noongar people of Perth, the Nilipana people of Hobart, and the Wathaurong people of Geelong. We also acknowledge the traditional owners of the various lands from where you are viewing today. We recognise their continuing connection to the land, the sea, and the community. We pay our respects to the elders past, present, and emerging. Learning to live with MDS can be challenging and stressful. MDS in the wider community is a condition that is not well known or understood. It is considered a rare condition. Some people refer to it as a blood disorder. Others refer to it as a blood cancer. However you look at it, MDS has far-reaching implications on one's physical and emotional health and well-being. In this webinar, we'll be covering the diagnosis, treatment, management of MDS, some of the emotional effects along with what is happening with the advancement of MDS treatment in research. Our hope is that the more informed you are, the better equipped you will be to live as well as possible with MDS and really enable you to make informed decisions. Okay, without further ado, I'd like to introduce our first speaker, Christine Heath. Christine is going to share her personal experience of living with MDS. Thank you, Christine.
Good morning, everybody. Thank you to the Leukaemia Foundation for inviting me to share my experience with living with MDS. I was officially diagnosed in April of 2016 at the age of 48. And I say officially because looking back, I think my health had started going south 3 years earlier. First indication should have been the family holiday, where I just couldn't keep up. I was constantly breathless and I needed a ridiculous amount of rest and rest days. Then in 2014, I started to really struggle at work. I'd been in a long-term leadership position and I just started not to be able to cope and didn't know why. I decided to step down from my role and headed back into the classroom as a full-time maths teacher. My fatigue was increasing. I was getting more breathless just walking around the school, and I was constantly dizzy and experienced kaleidoscope eyes. After fainting at school, I decided to go to the doctors, who ordered a blood test and referred me to a haematologist. It took a couple of years, but after a bone marrow biopsy, I was diagnosed with MDS, MPN, RAS-T. My husband and I decided to tell our daughter straight away. She's our only child and was 15 at the time. Regular haematology appointments and blood tests became my norm. I always, however, made sure that either my husband or my daughter came with me to any appointments that I had. At one of these, we were told all the statistics regarding life expectancy, treatment, and that the only possible cure was a bone marrow transplant. To me, it was a no-brainer. I decided that if the opportunity came along, despite the risks, I was going to have a transplant. Work was tough. The fatigue in particular was debilitating. So I told my work colleagues, as I thought I needed to explain to them why I wasn't coping. Everyone was really supportive. One colleague even bought me a notebook telling me it was to jot down questions day or night, so I would remember to take them and ask them at my appointments. 6 years on, I'm still using that notebook. Basically, it's become my memory. One of the hardest things for me to get my head around, and I don't think I ever did, was that I just didn't look or feel sick. I would tell people I had MDS, which was a blood cancer, and they would often reply, "But you look so good, you don't look unwell." They thought they were being supportive, and they were, but it often made me feel like a fraud. I'd explain to them that I was like an apple. I looked good on the outside, but on the inside, once you took a bite, I was actually all rotten and bad. I decided to go part-time and negotiated to change some classes, drop others, modify some duties. I was even allowed to miss meetings if I was particularly fatigued. Being part-time and living near the school, enabled me or allowed me to go home between lessons when there was a long enough break. This was really important as I needed lots and lots of rest during the day to get through. The principal also suggested that when the time came that I give up work, and when I had to give up work, to contact my superannuation scheme and see about accessing income protection. After talking with my haematologist and both of us completing the appropriate forms, I applied for and was granted income protection. It was one of the best decisions. I stopped work in September 2017, which was 2 years before my transplant. Now, I believe knowledge is a powerful thing. So like a lot of people, I focused on getting information from any source. That included connecting with others who had MDS. Facebook is wonderful, and they have groups for everything there. And I joined a couple of MDS groups. It was on one of these sites that I connected with 2 women, Fiona from Melbourne and Patty from America, both who had exactly the same diagnosis as me. We clicked straight away and started messaging and emailing each other privately. We decided to establish our own Facebook site to support people and families with RAS-T. It started with just the 3 of us, and now we currently have over 60 members worldwide. I've learned that although we may all have the same diagnosis, our symptoms and treatments may be similar, but they are very different. But the fatigue is pretty much common with all of us. Going part-time and then giving up work enabled me to continue to do all the things that I needed and wanted to do, like being a mum and a wife. I managed because I was able to rest whenever I needed. I could still do everything I used to. It just took me so much longer. When we went overseas for a family holiday, we made sure that we factored in plenty of rest days and afternoons. And if I was particularly fatigued, I just stayed in the motel resting while my husband and daughter went sightseeing. Like many from diagnosis, my treatment was watch and wait. They tell you this is a good thing, and it is. But this passive type of treatment is a little frustrating. People would expect it and would often ask if I'd started chemo. And I would always say, no, I haven't. All I have to do is take an aspirin daily. I know many of you already understand what the fatigue and dizziness is like. I also had ringing in my ears constantly. My skin was taking on an orange pigment. Most nights I had restless legs, and I would often be woken up in the middle of the night with cramps. I also started craving pineapple juice. I'm not sure, but yeah, pineapple juice. I could not get enough pineapple juice. Even though my daughter was still at school, she became my primary caregiver as my husband lived and worked away. He'd always come to my main appointments, but it was my daughter who did the day-to-day hard yards. About a year after diagnosis, I started to have blood transfusions. Whilst I was nervous, I was familiar with them because of my dad. The effect of the first transfusion was amazing, almost instantaneous. One day I could barely get off the couch, and the next day I was buzzing, dancing and jumping around. So much energy. Unfortunately, it doesn't always last that long. I always felt better after a transfusion. And I always knew when I needed my next transfusion. My transfusions to begin with were every 6 to 8 weeks, but time between transfusions got shorter and shorter. I then started EPO injections, which initially helped lengthen the time between transfusions, but it wasn't long before that stopped working. And basically my transfusions, I was having more and more transfusions, and it got to a stage where I was basically having them weekly. Because I was having more transfusions, my iron and ferritin levels increased, and so I started taking XJ, which is an iron chelation. I was allowed to manage my own transfusions in the sense that if I felt as though I needed a transfusion, I could book in. If my hemoglobin was around 90, I'd get 1 unit. If my hemoglobin was around the low 80s, I'd get 2 units of blood. 3 years after diagnosis, almost to the day, I was sitting in the day clinic chair having a transfusion when I got my phone call from my haematologist saying it was time to start the transplant process. Now, that's a day that changed my life, but that's a different story to this one. Living with MDS is hard work. I often felt tired, lonely, and scared of the future. I tried hard to embrace the new me, who took time to do everything, even the simplest of tasks, who was constantly fatigued and had to go to bed early, had to rely on others. My life was filled with medical and doctor appointments. Now, post-transplant, I'm lucky enough to be in remission, and whilst I haven't returned to my old self, life is better and more positive. I'd like to thank you for listening and wish you all the very best in your own fight against MDS. Thank you.
Thank you so much, Christine, for sharing your story. I think it's really beneficial for people to be able to hear someone else's personal experience with such honesty, especially, you know, the way that it's affected your family and your normal life and how you managed that and were able to, you know, accept that MDS was here and changes had to be made and how you went forward with that. That's great. We appreciate it. Thank you. I'd like to introduce our second speaker, Associate Professor Melita Kenealy. Associate Professor Melita Kenealy is a clinical haematologist at Cabrini Hospital in Melbourne, where she is head of the cancer services and chair of the medical leadership group. She is an investigator on numerous clinical trials, including in MDS, with Cabrini being an MDS Centre of Excellence. She is an associate professor at Monash University, and she provides supervision to both medical students and advanced trainees in haematology. Associate Professor Kenealy has nearly 20 years of experience working on research in MDS and epigenetics, which was launched with a scholarship from the Leukaemia Foundation, and chairs the steering committee for the MDS Link and MDS Registry. Morning, Melita. Please take it away.
Thank you so much, Linda. Yes, my MDS research and career really started with the Leukaemia Foundation nearly 20 years ago. So it's nice to be coming back and speaking to people about MDS. So today I'm really going to be talking about understanding what MDS is as a disease, about the blood cells and the bone marrow. But it's so good, as you say, to hear from Christine about the impact of that for our patients and for people living with MDS. We'll touch on some of the different treatments for MDS and considering best supportive care and other treatments. So I'm going to just share my screen, and please let me know if that's coming up. I apologise if it's not an ideal share, but if that, I've got some nods from people. So we'll talk about MDS and some treatments and how we approach the treatment of MDS, and also looking a little bit towards the future and trials, and I'll hand over to Ashwin for some of the research happening. So what is MDS? Well, I'm sure many of you know that this is a group of disorders and they vary quite widely, as Christine stated. So it's a disease of the bone marrow. And as we heard about, some people call this a cancer, but it's a cancer-like abnormality in those stem cells in the bone marrow. And the result of that is that the bone marrow, which is our factory to make our blood cells, becomes ineffective. So the blood cells are very complicated in the bone marrow, as you can see in this chart. And then these are the sort of circles over to the right-hand side, which are the blood cells that we see when we take a blood test and look under the microscope. So what we see often is that the blood counts or the blood cells are low. MDS is not a very common condition, and I'm sure many of you have faced family and friends who've never heard of this condition. And this is a little bit old, but it's probably about 13 to 1,500 of new cases per year in Australia are diagnosed with MDS. And if you compare that to some of the other blood diseases, so plasma cell myeloma or lymphoma, for instance, we have 4,000, upwards of 4,000 people per year diagnosed. As you can see from the graph on the right-hand side, this is a disease that is very uncommon in their 40s, Christine, but certainly much higher as people get into their 70s and 80s. And so the average age that we diagnose people is about 75 or 76 years old. The symptoms of MDS are generally related to the low blood counts. And you'd all be aware that there are the three main blood cells that you can see in the picture up the top. So there are these red blood cells, which are the most of those cells in the picture, and they're the ones that carry oxygen around the system. And if they're low, then we're anemic. And that causes this fatigue, often breathlessness, ringing in the ears often happens, dizziness, and just not having that sort of get up and go. The white blood cells are the sort of purpley pink ones in the middles, and the neutrophils are the most important of those. They're the white blood cells that generally fight infection, particularly bacterial infection. So if they're low, people tend to have risk of recurrent or severe infections. And finally, the little guys here, these little platelets, they're there to stop us from bleeding and bruising. So generally speaking, they're low in people with MDS, though there are different subtypes or types of MDS where they might, for instance, be high. But if they're low, then the risk is of bleeding and bruising. We're aware that in addition to these low blood counts and the symptoms, that there is a risk with people with MDS. Overall, about a third of people who are diagnosed with MDS will progress on to an acute leukemia, which is a serious cancer of the white blood cells in the bone marrow. And that's something that's often in the back of our mind. How do we assess people and make a diagnosis of MDS? We take a bone marrow biopsy. Now, often we'll have clues in the blood tests that people might have MDS based on the appearance of the blood cells. But we do a bone marrow biopsy, which is popping a needle into the inside area of the bones, usually in the back of the pelvis bone there. And we're doing that to assess and make a diagnosis of MDS, but also looking at all the different cells and the balance of cells, whether there's a concern that there might be too many leukemia-like cells, but also doing some fancy tests called cytogenetics or sometimes molecular testing, which is helping us to establish exactly what subtype or type of MDS this might be, and trying to predict what the behavior might be of this MDS in a particular person. So there's blood tests that we do. We'll often check on some vitamins and other hormones to see if there's other things contributing to anemia, for instance. But a bone marrow biopsy into the center of the bone is the way that we make this diagnosis. The picture down the bottom is the cytogenetics. So they're all the chromosomes that we're looking at inside an individual cell in the bone marrow that might help us with working through what the different types are. I popped up a couple of examples of some blood tests that you might be familiar with your own blood tests and how they appear. And I'd encourage you to ask for print-offs of your tests when you're talking to your haematologists. So we do a full blood examination or an FBE or an FBC in some labs. And what we're looking at is this hemoglobin. These are lots of different markers of the blood cells, but the other important ones you'll remember are the platelets here and the neutrophils. So in this patient, we can see that the hemoglobin is 90. With a normal range, it should be about 125. The platelets are also low, and the white cells are normal, the white cells are normal and the neutrophils are normal here. But there's a few other things going on which are in the red, which are abnormal. So it's important to get to know your own blood counts. And as Christine flagged, she was aware of how her symptoms would change depending on what her hemoglobin is. And that's really important to establish. So just another example where we're looking at the hemoglobin, the platelets normal in this situation, but the neutrophils are low. So everyone has a very different way of presenting with MDS. No two people are alike, you're all very unique, and we need to manage things individually. So we need to manage things depending on your own symptoms and your own concerns. So I've talked about subtypes, and we do classify MDS, and I'm sorry I can't make this any more interesting, this slide. It's lots of technical words around the different types of MDS. So we have MDS with single lineage, meaning just one of the blood cells is affected, or other types where 2 or 3 of the blood cells are also affected. This is one of the types that Christine's alluded to. And we talk about these overlap syndromes as well, which are rare, but they're important for us to work through, that they have shared features with some other conditions as well. But it's important to know that this is all based on the different cells that are affected, whether it's all three or just one or two, the number of these, what we call blast cells. So the blast cells are the leukemia-like cells that can be in the bone marrow, and we want to have those nice and low rather than going up. We're also looking to see the appearance under the microscope, and we're looking at the chromosomes or the cytogenetics, which help us work out which of the subtypes or classifications here. So that gives us the diagnosis and a type, but we also like to look at what we call risk scores. And it's the IPSS or the IPSS-R, which are the risk scores that we talk about in MDS. And these are based on factors that we've looked at in hundreds and thousands of patients with MDS from big trials and databases to work out which features make us more or less worried about someone's MDS might change very quickly, or it might stay fairly stable over time. And that can help us inform people, and they can make good decisions about their MDS and also about what the best treatment might be for someone. So this is defining groups of patients who might have similar sort of pathway or a journey with MDS, but it's really important that you realize that this is only averages. And again, individuals need to talk with their haematologist about what their own factors are and what are the things that are worrying or less worrying about their MDS. So again, we look at the number of those leukemia-like cells in the bone marrow, the chromosome abnormalities, and the number or how badly or how severely those blood counts are affected. I've got a couple of quick slides, and I don't want to get into too much detail about how we come up with all of these scores, but remembering that these are the factors that we're looking at: the blast cells in the bone marrow, the cytogenetics, and how many of the blood counts are affected. Basically, we allocate scores and we add up the scores of all these things, and we roughly group into what we think the risk of this MDS of causing trouble sooner or later, and whether we think it's likely to progress on to that AML or that leukemia. So we generally group these MDSs into people with lower risk disease and higher risk disease. And that helps us as clinicians to try to give you better information about MDS, and it might help us with how to treat things. So this is the older score, which is a bit more simple. The newer score, and again, I won't go into the detail, it depends a little bit. In the top right, you can see exactly what the blood counts are with the hemoglobin or the platelets or the neutrophils that will give you different sorts of scores. And we now have 5 risk categories that we talk about, from very low, low, intermediate, high, or very high risk. Ashwin is going to talk a lot more about molecular details within MDS, but even beyond looking under the microscope at the cells, we now have a lot more information, which was not available when I started in MDS many years ago, about what some of the faulty genes or what we call mutations are in the cells in the bone marrow. And this is a graph that was published a few years ago, but it gives you an idea of how complicated all of this is. So you can see along the bottom here, these are all genes that can become faulty in people with MDS. So the most common one is this one called SF3B1. And you can see that in 700 patients, over 150, nearly 200 people had this faulty gene. And the different colors of that bar just represent the different types or subtypes of MDS who had that faulty gene. So we're starting to learn a lot more about what these gene faults are and how they might impact on someone's disease course or what's going to happen with their MDS. But also, this is now getting us into areas where we might be able to choose a treatment that's better suited for someone with a particular faulty gene, for instance. And some of the new treatments coming through, I can give you an example, luspatercept, which is a new injection that we can use to try to improve red blood cells, works particularly well in people that have these ringed sideroblasts, so these RS subtypes, or with this SF3B1 faulty gene, for instance. So this is really helping us with how we might be able to choose treatments for people that are better suited or more individualized. So that leads me to treatment. And I want to pause on this because I think these next two slides are really important to think about, again, this individualized care for MDS. And there's not going to be one size fits all for people with MDS. So we talk about best supportive care in MDS, and that should be for everyone, whether people are having active treatments or whether they're on what Christine mentioned is watch and wait. And it really resonated with me, that frustration around watch and wait, because this is something that is frustrating for people being told you've got a condition or an illness, but we're just going to monitor things and we're not going to introduce any treatment. But I'd like to think that we're trying to manage people's symptoms and complications, irrespective of whether we're using treatments as intensive as transplant or whether we are truly monitoring things in the first instance. And I haven't listed education here, but I completely agree that information and education is empowering for people to make sure you're asking the right questions for your own particular MDS and your treatment path. So best supportive care is education and information, managing symptoms, and that might be with blood transfusions, for instance. It might be with some other simple treatments to try to boost up the blood cells. But it's really important, and we're learning more and more about this. Holistic care, it's managing your general health, it's making sure you're keeping fit and healthy, looking after any other medical conditions that you have, having a really good relationship with your GP that can help advocate for you if there are questions or issues. And we know that exercise is really important, but hard to do when you're really fatigued. So I often have patients seeing exercise physiologists, for instance, and talking to our allied health people to formulate a life plan and a wellbeing plan to keep you as well as possible for as long as possible. So we need to consider all of the impacts of a condition like this on your psychological well-being, the practical things, and I'm really pleased, Christine, you talked about income protection and finances and work and care roles, and all of those things are actually really important. Care planning, strategy, or what the sort of the path or the journey of MDS is going to be really important, and that's going to be different for every person. And that's also going to include things like introducing palliative care or looking at changing treatment choices as we go. So it's important that these things can change across time, as it certainly did with Christine, starting on a watch and wait, moving to transfusions, and then to more active treatment. So things do change over time. If we think about active or specific treatments, this is where the type of MDS and the risk score really come into play. And we have treatments for both lower risk and higher risk types of treatment. Lenalidomide is a tablet or a medicine that's available for a small group of people with particular changes in their cytogenetics with lower risk MDS who might require a lot of blood transfusions. In people with higher risk MDS, where we're concerned that this may develop into leukemia, we have treatment with azacitidine, which I'll touch on, which is a low-dose chemotherapy injection. We have, in a small group of people, chemotherapy might be appropriate, but we use that less and less these days. And as Christine said, a stem cell or a bone marrow transplant is at this point the only treatment that has the possibility of a cure of MDS. And that's only available or appropriate actually for quite a small number of people with MDS because of our average age of MDS and often other medical problems that people might have, that this is maybe not the most appropriate treatment for everyone. And we do have clinical trials and new emerging treatments that are always worth keeping on top of. So the goals of treatment, and again, this is a really important thing to reflect upon, because we generally don't fix or cure myelodysplastic syndromes. So whereas in some people, we might use a really intensive treatment like a stem cell transplant to try to cure things, most of the time we're trying to help people live with MDS as best they can. So we want to ensure that we're selecting a treatment which is best suited to an individual. We want to minimize side effects and toxicity, and it will depend on the type and the risk of the MDS, the individual, other medical conditions, how old we are, and really importantly, what the individual and family wishes are. And that's a discussion with your haematologist to choose the best path. And as I've said, this does often change over time. Either the disease will change, people can change their mind along the way, a new treatment might emerge, people might have treatment that stops working. Announcements. And it's important that we reassess things along the way. Our goals of treatment are twofold. One goal of treatment might be just to reduce the impact or the complications of the low blood counts. So it might be to reduce the transfusions that someone's having because they're causing troubles and interfering with their quality of life. It might be to try to reduce the infections or bleeding troubles. Or our more directed treatments like transplant might be to try and change or fix the MDS in some ways, or to prolong someone's life. So those things, best supportive care, and I've touched on anemia and red cell transfusions, EPO injections, which can boost things up. I've touched on infection, and mostly it's monitoring for fevers and infection and getting onto antibiotics quickly. Or it might be, in some cases, if people are sick with an infection, some injections of GCSF. Sometimes with bleeding, we'll give platelet transfusions if people have active bleeding. We need to be careful with procedures. And there are some other medications that can be useful for people that have more significant bleeding troubles. I wanted just to touch on anemia and transfusions for a little bit, because that's something that can be a real problem for people with MDS. And you can see here that in the different risk groups of anemia, between 40% and up to 80% of people in the high risk groups can be dependent on red blood cell transfusions. The reason we do transfusions and make people feel better, because the red blood cells are involved in delivering oxygen to your tissues. So if your red blood cells and your hemoglobin are low, then you're not able to get oxygen off for all your organs to function well, and you'll feel fatigued. And we know that anemia in both men and women is reduced not just with reduced survival, but high risk of other diseases and poor quality of life. And I think Christine sort of flagged that with us, struggling physically and also with an impact on work and family and other life. And you can see when we do surveys of people's quality of life, people that have anemia, so if they're anemic, we have lower scores in overall quality of life, in functioning physically, in their role, in social roles, emotional functioning, and even cognitive functioning. So anemia has a big impact on people's quality of life and functioning. They also generally have, and Christine's flagged, the dominant symptoms are fatigue and dyspnea, which is breathlessness, would be the most common symptoms. So we have to balance the risks and benefits of transfusion when we're making a decision about how and when to transfuse. We want to improve the symptoms and reducing the complications of being anemic for a long period of time, and improve the quality of life, make people feel better and function better. But we know there's also a few side effects to the transfusions that we need to manage, including overloading people with iron, which happened when Christine had many blood transfusions. There's a small risk of reactions, and obviously the inconvenience, needing lots of appointments and time out of work or other roles, transport to transfusions if people live regionally, for instance. And we're doing a bit of work and some of the group that I work with on just the resources required for blood transfusions. So to talk about the triggers is difficult because it is individualized. There's no consensus on the best level of hemoglobin for us to do a blood transfusion for people. And that does need to be individualized. For some people, they have significant symptoms at a hemoglobin of 95 and would need blood transfusions. But other people can get down to 85 or 80 or even 75 and have very few symptoms. So we really need to individualize and balance the symptoms with the number to decide and make a plan for how many transfusions. How many units of blood do we give and how often do we give them? What are we aiming for and what's the trigger? And a Monash Uni group are doing quite a bit of work on this. In Australia, we're quite restrictive. So we tend to wait until the hemoglobin's dropped quite low, under 90, before we do transfusions. And in the UK and in Europe, you can see that most people get down to 80 or 82 before they have a blood transfusion. I've got a couple of graphs and I won't labour over these, but this is just a couple of my patients that I've treated in the past. These are their transfusions with a little picture of the red blood cells, and you can see that they were getting down to even 60 and 70 and needing a transfusion. This patient had azacitidine, which improved their blood counts, reduced their need for transfusion for a period of time. But even when they weren't getting transfusions, you can still see in this latter part, they were still below the normal level of hemoglobin, which is in that grey area between the two red lines. This is another patient who had a particular syndrome of MDS called 5q-, and they had low levels and then they dropped quite dramatically, and you can see how many blood transfusions they needed there for a period of time. The little green circle is a short period of time that they had lenalidomide, which is a treatment to try to improve transfusions. And you can see that that made a difference to their hemoglobin just for a short period of time. There are different sort of strategies and patterns, if you like, and maybe this is a way that you could visualize. You know, some people might get only 1 unit or 2 units, other people will get 3 units. And I guess thinking about how often you're having transfusions, how many units you're getting and what your hemoglobin's looking like, I sort of think of this sawtooth. You go up after the transfusion and then it drifts down again. And this is something for you to work on with your haematologist about how often to try to minimize the complications and side effects and get a balance right for you. The REDS program has been some clinical trials looking at this exact question. Are we better to wait until people drop really low and give them lots of blood? Or are we better to do something like give 1 unit really frequently? And does that help people's quality of life? So this is some clinical trials that have been run and currently open, REDS 2 through Monash, looking at the different ways that we do transfusion strategies. There's lots of practical things to consider. We obviously don't check a hemoglobin every week. And I tend to book people for a transfusion so that they know when it's going to happen down the track so they can organise their life around that. It's a bit more convenient and predictable. But I like to hear what Christine flagged, that she had an arrangement that she was able to book a transfusion when she felt that her blood count would be dropping low and she had more symptoms. So iron overload we've touched on as a complication, and Christine's talked about Exjade. This is a medication, D-Farazerox, which is now available through the PBS on tablets. The new version is called Jadanu. It's a new formulation, and that's used to reduce the burden or the loading of iron that happens when people have lots of blood transfusions. And generally, we start that treatment when people get to about 20 units of red cells, and that's often when we see the ferritin level or the marker of the storage iron getting up to about 1500. And the problem with this is that it can cause some damage to your heart or your liver or other organs. And so we'd like to reduce that back if we can. I'll touch on a few other treatments, and I know that some people might have heard of EPO, which is erythropoietin, which doesn't work in everyone, but can be useful, particularly if people have low kidney functioning. I've touched on needing education and managing infections, and that's really important to have a thermometer at home and to see your doctors if you've had an infection, and managing low platelets, the third main blood cell. And generally, traditionally, we only give transfusions if the platelet levels are getting very, very low. I'll touch on some of the disease specific treatments for firstly lower risk and then higher risk MDS. And these ones I've mentioned. This is lenalidomide, which is called Revlimid, which is available for people with very specific blood subtypes of MDS. And this graph you can see, which was a trial looking at the hemoglobin level on the left over time in people who had placebo, which was nothing. You can see that made no difference to people's hemoglobin, but the lenalidomide, either at 5 or 10 milligrams, improved the hemoglobin steadily over 6 or 12 months in a proportion of people. So that's certainly worth asking and considering in a small group of people with MDS. I touched on luspatercept, which is a new treatment that is only available on clinical trials at the moment, but we're hoping will become available in the coming years. And this is something developed overseas in trials, and it's probably best in people who are dependent on blood transfusions in lower risk. And I mentioned the ring sideroblasts and some specific gene faults that we see. And over half patients on this treatment require no further transfusions while on the treatment. We don't know that this is necessarily a long-term strategy, but it's certainly a very promising one. For higher risk MDS, we've talked about azacitidine being an injection of low-dose chemo, which actually works through different means. It works through what we call an epigenetic way to try to reprogram your bone marrow to produce more effective blood cells. And this was some of the work that I did very early in my career, looking at azacitidine. And this is something that you might all be familiar with, but it's given for 1 week, generally every month, and it's ongoing treatment. So that's quite a heavy burden of treatment that can be quite tough for people. The most common side effects are often in the first 2 months, where the blood counts can get worse before they get better. Some people get trouble with constipation or diarrhea, and unfortunately the injections do often cause a bit of soreness on the tummy, and that can be difficult to manage. And responses are fairly slow, so it usually takes 2 to 4 months to get an effect, a good effect of this azacitidine. But we know in the pivotal study that was published over 10 years ago now, that about half people had some improvement in their blood counts. And this was azacitidine, and we compared it to people having just best supportive care or a low dose other chemotherapy or what we call standard chemotherapy. And that improved people's blood counts. It reduced the risk of people developing leukemia, and people generally, on average, lived longer on the azacitidine. So that's certainly what we would call standard treatment for people with for higher risk MDS. But importantly, we need to consider not just these disease sort of markers, but look at quality of life. And it's no good if the disease gets better, but people feel dreadful on the treatment. So this is another trial of azacitidine where people did reports of how their health was and their quality of life. And this was a trial where half the people didn't get the azacitidine, and this dotted line is for those people that then crossed over and got the azacitidine. And you can see that their quality of life was getting worse. Their physical functioning was getting worse. Their fatigue and shortness of breath was getting worse before they got the azacitidine. And when they had treatment, things did generally turn around and get better. So that's a good sign that things were improving. So there is a lot going on in MDS research, and I'll hand over to Ashwin in a minute to talk a little bit more about that. There is definitely a demand for better treatments, okay? We definitely need to improve things for people with higher risk MDS, to improve the number of people that respond to the azacitidine, and these are a couple of drugs that are being tested at the moment, magrolimab or something called venetoclax. And we need to improve things when the azacitidine stops working, because we're in a very difficult situation and that's very difficult to treat. I've touched on some of these new treatments in people with lower risk MDS, the luspatercept, something called imetelstat, and there is a tablet version of azacitidine and another related one called decitabine, which are being developed and hopefully will come through in the coming years. We need better combinations, and we need better drugs to treat these gene faults that we discover. And as I've tried to highlight, I think rather than just trying to fix a bone marrow or improve a blood count, what's going to be really important is asking our patients how that treatment's going, what's their quality of life, and what we call PROMs. What are our patient-reported measures? How do people feel, and how are they responding to these treatments? And of course, trying to improve the transfusions and the supportive care. So I'll leave with this last slide, which is obviously very busy. This is some data from the MDS link, which is a pilot registry in MDS that I'm steering, and this is across 4 different hospitals in Victoria and South Australia at this stage. And we presented some of the summary of 127 patients with MDS who we have on this registry. And this is all to try to really work through who our patients are in Australia, what are their needs, what treatments are people on. And I think from gathering data like this, we can really then contribute to improving treatments for patients with MDS in Australia. So I'll leave it at that. I'm happy to take questions maybe afterwards and maybe hand over to Ashwin.
Thank you so much, Melita. Thank you very much for that. We really appreciate your insights, especially about how MDS isn't just simply a disease. There are many subtypes to it, and that's a very individual thing with each person that you treat. And I think it's really great as well that, you know, you talk about the importance of the quality of life and not just focusing on there's this medication or a blood transfusion. I think that's very helpful for people to know that, you know, it's okay to be talking with their doctors about that part of what it is for them. Okay, so I'd like to introduce our third speaker, Dr. Ashwin Unnikrishnan. So Dr. Ashwin Unnikrishnan is a senior lecturer and head of molecular mechanisms in Leukaemia laboratory at the Lowy Cancer Research Centre in the University of New South Wales, Sydney. Dr. Unnikrishnan is an expert in translational cancer research, combining expertise in stem cell biology, epigenetics, genomics, molecular biology, and bioinformatics. His research discoveries include 26 scientific manuscripts, have led to 2 active clinical trials in leukemia based in Australia, and a patent application. He has successfully led international collaborations involving multiple stakeholders, including leading academics, oncologists, and global pharma, which have led to high-profile medical discoveries. Dr. Unnikrishnan is a principal investigator on active grants from the National Health and Medical Research Council, Leukaemia and Lymphoma Society of USA, the Leukaemia Foundation Australia, Snowdon Foundation Australia, and the Medical Research Future Fund, which is Australia, that support research in his laboratory. He is a 2019 awardee of the Cell Gene Future Leaders Award for Clinical Research in Haematology, a 2018 recipient of the Translational Research Training in Haematology Award, jointly from the American Society of Haematology and the European Haematology Association, and the University of New South Wales Rising Star Award 2012 for research excellence. He serves as an active reviewer for numerous top-tier scientific journals, major international grant agencies, and as a PhD examiner for Go8 universities. Thank you, Ashwin.
Thank you, Linda, and thank you to the Leukaemia Foundation for this opportunity. And I'm really looking forward to sort of presenting our research to the people that it hopefully will matter the most to. And I must thank both Christine for giving this personal insight. You know, a lot of times when we do research, we can be a bit distanced from the coal face of what it all means. And to Melita for really putting out there, a lot of the questions that we really should be thinking about as we go on in our work as well. So I will share my screen without any further ado. And today, I hope everyone's able to see this as well. So today I'd like to talk to you about the research perspective in MDS. And as was mentioned, so I lead a research laboratory based at the University of New South Wales here in Sydney. So to me, understanding leukemia, you have to understand this fascinating process of hematopoiesis, which is driven by stem cells, which reside inside the bones of all of us. 100 billion new blood cells are produced on a daily basis. And these estimates differ between studies, but 200 billion red blood cells on a daily basis, 250 billion platelets, 50 to 100 billion granulocytes, and all of these arise from these things called hematopoietic stem cells that reside in the bone marrow. And because of this rapid proliferation of cells giving rise to all blood in all of us, it's also prone to errors. And those can be genetic mutations, epigenetic alterations, and I'll sort of walk you through what some of these things mean. But the end result is a cessation of normal blood cell production. And I will try and get my pointer so that you can see this as well. So cessation of normal blood cells and conversion of healthy cells into what we think are called leukemic stem cells, which drive the leukemogenic process as well. And we and others have kind of shown evidence that suggests that similar things also happen in MDS. So a real focus of my lab's research is hematological cancer. So we study MDS, which has a personal and professional affinity for me. We also study the more pernicious form of leukemia called acute myeloid leukemia. And we've increasingly also started studying leukemias that arise in younger individuals as well, including a form called TALL. And the primary interest of what we do is really driven by trying to understand why do these diseases arise, so that we can then use that information to improve the treatments of the future, and also understand why treatments of today do not work, so that we can then glean some understanding into the processes that drive leukemia as well. And science today is complicated. And so we use a multitude of different techniques, including cutting edge techniques such as genomics, proteomics, and stem cell biology, and computational techniques because of the huge amounts of data that we generate on a daily basis. And a lot of our work today that I will talk to you about have come directly from samples contributed by patients who have enrolled on clinical trials, but we also utilize cell lines and samples that have been transplanted into mice in order to be able to understand the biology and the effects of treatment as well. So I do have a personal connection to MDS. A grand uncle of mine passed away from the disease more than 20 years ago, prior to the advent of azacitidine. And just hearing a lot of the things that Christine touched upon and what Melita were talking about, the effects of persistent transfusions and the real horrible quality of life that led to, sort of left a mark in my life and has driven my research in some ways. And my professional interests. So I did my PhD in a field called epigenetics in Seattle at the Fred Hutchinson Cancer Center, which is where E. Donald Thomas pioneered bone marrow transplantation, for which he won the Nobel Prize in 1990. So there have been two different tangents to my life that have both led to MDS. And as Melita had shown earlier, there are a lot of faulty genes in MDS. So more than 50% of MDS patients have some sort of cytogenetic abnormality. And this is also used to classify some of these subtypes of MDS, which Melita had described. And you can see a plethora of different genes that are mutated to varying extents in MDS. But they all sort of impinge upon a set of pathways. And a lot of this finally comes back to epigenetics, which is really my area of expertise and what I got my PhD in. So we find a lot of genes that are mutated in MDS patients affect how genes are turned on and off. And it all has to do with the DNA that resides inside every single cell of our body, including the hematopoietic stem cells. There are also mutations that affect how genes are turned on and off. There are things called RNA splicing machinery, which is an active area of interest in my lab and affects how RNA that comes out of single genes are controlled. And what we are realizing is all of these processes are faulty in MDS patients. We don't fully understand how they contribute to the disease just yet. But we do know that some of them are more important than others in some ways. So we know that certain mutations exist early on in the evolution of the disease, and they set the stage for acquisition of more mutations and worsening of the disease over time. What's also known, and it's been known for many years now, is there's this phenomena called clonal hematopoiesis that exists in leukemia, including MDS, which means that out of a possible large number of hematopoietic stem cells that an individual has, most of the blood that arises late on in the evolution of the disease arise from a small set of stem cells that contain a lot of mutations. We don't really know what's driving this, but we think some of these mutations that these stem cells acquire early on in the disease progression might be contributing to clonal hematopoiesis. And Melita touched on this beautifully, so I won't belabor the point, but there are various treatments, but really for high-risk MDS, the disease-modifying treatments are stem cell transplantation, if an individual is able to tolerate it, or this drug called azacitidine that really drew me into studying MDS. Azacitidine failure, though, is a pressing clinical problem. So more than 50% of individuals will not respond to azacitidine upfront. It really needs about more than 4 months of treatment to know whether an individual will be one of those fortunate responders or will not respond to treatment. And if you do fail azotherapy, there's a lack of currently available therapies. And the other arm of this is that for the 50% where you do see initial responses, the response is not sustained long term, and a significant fraction of individuals will relapse, unfortunately. So we really need to understand why azacitidine treatment fails in high-risk MDS, and that's really driven my research over the last 10 years. And the discoveries that I'll talk to you about today about why azacitidine fails have really arisen from studying samples that individuals, patients undergoing treatment in clinical trials have contributed, and applying all of these technologies onto it to be able to understand what's going on. So what is azacitidine? Azacitidine is what we call a ribonucleoside. So a quick primer on biology. So every single cell has DNA. The DNA has genes which encode for RNA, which in turn create proteins that are responsible for everything that happens in a cell. The DNA is made up of nucleotides. So there are 4 flavors of it, and one of them is called cytosine. And azacitidine is an analog of cytosine, and it's almost identical to it, except it has this nitrogen in place of a carbon. And what aza does is when it enters the cell, it gets transformed by the cell and then goes into DNA as DNA replication happens. And it has this effect called an epigenetic effect. And what if anyone's interested, the particular effect is called DNA demethylation. So this is generally what is thought to happen with azacitidine when it goes into a cell. So we, starting from that basis, asked a question of why is it that 50% of patients fail to respond to azacitidine? Is there something pre-existing in them that predicts whether they will respond to treatment or not, instead of having to wait and watch over 4 or 6 months to determine an individual being a responder or non-responder? And a lot of effort has gone into this, but again, this is all worked on primary samples and utilizing techniques that are cutting edge. Work we published, and I'll condense it into a schematic here for a lot of effort. what we have found is individuals who do not respond to azacitidine compared to those who do respond have similar levels of aza that go into the cell, but the amount of DNA replication is less in the individuals who don't respond. As a consequence, less azacitidine goes into their DNA, and we think less epigenetic changes occur in them compared to those who do respond favorably. And this is just data from a very commonly used technique called flow cytometry, and you can see that effects of this quite clearly. So in a healthy individual, and all you have to do is just focus on the boxes I've drawn here. In a healthy individual, about 4% of cells are what we call cycling. In MDS patients who respond to azacitidine, it's similar, but in the non-responders, it drops quite dramatically, as you can see here as well. And the fraction of cells that are not cycling are smaller in healthy individuals, but dramatically increase in the individuals who do not respond to treatment. So why is that so? We have identified a molecular pathway that we think is driving that. And it's to do with this protein called integrin alpha-5, which seems to be highly upregulated in patients who don't respond to azacitidine treatment. And in vitro, at least, we can show using chemicals that if we block this integrin, we can actually improve the sensitivity of cells to azacitidine. And it does in the patients who didn't respond to treatment. And it doesn't really change in those who responded because they don't have as much of integrin alpha-5 and therefore shouldn't respond differently. So to summarize, we think the basis of primary resistance to azacitidine in patients is because there's a fraction of less cell cycling or more what we call quiescent cells in the patients who don't respond, the stem cells or the progenitor cells in their bone marrows, and that's linked to a particular molecular pathway. So that sort of leads itself to a few different things that we could try and do to improve the rates of azacitidine response in individuals. We also developed a technique called AZA-MS, which allows us to actually quantify the amount of azacitidine that goes into the cells of patients as they get treated with azacitidine. And the development of this technique was really driven by a former student in my lab, and we published this a couple of years ago. But that has really allowed us to sort of drive 2 clinical trials that have just begun in MDS based in Australia. So the first one is we asked this question, and this is a drug that Melita just talked about, an oral formulation of azacitidine called CC486. So standard azacitidine is given as 7-day injection treatments, and then patients go off of it for 20 days, and then the cycle continues as well. But if individuals don't respond to azacitidine because their cells are not replicating or not dividing as frequently, the question then becomes, could prolonged in vivo exposure to a drug be more beneficial? And a potential for that is through this oral azacitidine, because you can give it for 20 consecutive days. You're not injecting an individual for just 7 days up front. And we can use the AZA-MS technique to ask, are there quantitative differences between these? And so that has really led to an ongoing clinical trial, and this is registered on clinicaltrials.gov, and it's in partnership with Celgene. It's a phase 2 multi-center study looking at patients who are eligible to receive injection AZA, and individuals get injection AZA for the first 6 cycles and then switch over to CC486 for another 6 cycles. The second thing that comes out of our discoveries is this thing about integrin alpha-5, which in vitro, outside of the body, we showed that it's linked to integrin alpha signaling, and blocking integrin signaling improves AZA sensitivity of cells. So a hematologist pursuing his PhD under my supervision has really taken this work on further, and he's shown using clinically available small molecules of drugs that you can actually target a kinase that's a protein that's further downstream of integrin alpha-5, and it seems to show efficacy in vitro and in preclinical work. And that has led to a second clinical trial in combination with a couple of pharma funded by this MRFF grant, which is looking at combining azacitidine with this inhibitor of integrin signaling called defactinib to look at whether we can do something for the individuals who fail to respond to azacitidine alone. Obviously, these are clinical trials, so the proof of the pudding, as it goes, is in the eating. We'll know over the next few years whether these are viable things. But this just gives you a flavor of some of the translational work that we initiated in the lab and how it is pointing away towards potential treatments to improve azacitidine response. But there's a second aspect of it, which is going beyond the here and the now and identifying more effective or better therapeutic targets in MDS. And I like this cartoon because it encapsulates a lot of what I would like to try and say with this statement here. So this individual is looking for the quarter that he's dropped under the lamppost, and he's asked, did you drop it here? And he says, no, I dropped it 2 blocks down the street. And why are you looking for it here? Because the light is better here. And that's a fallacy that we tend to fall into. We sort of look into things that we understand better, but those might not actually be explaining the disease at all. And those might not be the most effective ways to treat the disease ultimately. And so on this theme, I'm indebted to the Leukemia Foundation and the LLS in the US and Snowdome, who are supporting our work in trying to go beyond this lamppost and look at alternate ways that we can target and treat MDS. And one of those is a biological phenomena called RNA splicing. And RNA splicing is fascinating because more than 95% of every single gene in the human body is subject to this biological mechanism. And it's, without going into the details of it, it's just the way that a cell controls the output of a gene into creating various flavors of proteins from a single gene. And accurate RNA splicing is essential for the normal functioning of a hematopoietic stem cell. And we're increasingly starting to realize that inaccurate RNA splicing happens in leukemias. So Melita touched on this earlier. So in certain forms of MDS, a large fraction of patients, over 50, 60, 70% of individuals have faulty genes or genetic mutations in genes that control this process of RNA splicing. We still don't understand how any of this contributes to the disease, and we're quite a way away from working out how we could harness this knowledge to create therapies. But that's work that's underway in my lab. But these are the themes that we are sort of working under. So we're trying to understand, how do these mutations cause MDS? What about MDS patients? There's 20, 30, 40% of MDS patients who do not have mutations in RNA splicing genes. Is the RNA splicing pattern normal in those individuals? And I can give you a little insight into our early findings that it isn't. And can we ultimately leverage any of this information to develop new therapies that specifically target the MDS cells? About a year and a half ago, using some of these techniques that we are bringing to bear in MDS, we applied them to acute myeloid leukemia, which is a disease with a far poorer prognosis than MDS. And unfortunately, a fraction of individuals with MDS who fail to respond to treatment will transform to AML. The frequency of faulty RNA splicing genes in AML is far less than in MDS. But we asked the question, what is the RNA splicing normal in AML patients? And the answer to that is no. So we find that it's still messed up for reasons that we don't understand, but it also has a poor prognosis, is associated with poor prognosis in acute myeloid leukemia. And this was work driven by a postdoc in my lab. And what we have done with a variety of different computational and bioinformatics techniques is identify the missplicing of just 4 genes that can actually portend poor survival in AML and poor response to chemotherapy up front. And it's also indicating pathways that we think are driving chemo resistance in AML. And we're trying to reverse those pathways in order to restore sensitivity in AML. And we're working on very similar themes in MDS in trying to identify new ways to treat MDS, going beyond azacitidine and beyond the drugs of today. And hopefully, in the best case scenario, these might be therapies that Melita might be talking about in 10 years, applying onto her patients. And as I sort of move towards the conclusions of this, I just wanted to reflect on what I think are some of the next steps in MDS research. One of the things that we're increasingly starting to realize is these things, so MDS doesn't exist in isolation. We used to classically think of MDS as a different disease to acute myeloid leukemia. And those were driven by classifications of what you can see under the microscope. So certain, at some level, arbitrary blast percentage calculations beyond which you were AML. But one of the things that united them was this aspect of what's called clonal hematopoiesis that exists in both MDS and AML. But we're starting to realize with the advent of new technologies that in a large fraction of, some fraction of so-called healthy individuals, people who had no hematological disease beyond a certain age, they start to have clonal hematopoiesis as well, but they do not have any other symptoms of any of these other diseases. And it's starting to increasingly be thought that there's a spectrum along which individuals lie as they go, as they age, unfortunately, and certain things predispose, or certain molecular changes happen to the stem cells that predispose individuals to potentially form, moving ahead with hematological cancers. The paradigm for treating leukemias or MDS with chemotherapy, for example, has always been, well, you've got these faulty stem cells that become leukemic stem cells driving leukemic blasts. So we apply something that kills a lot of these cells and therefore eradicates the disease. But unfortunately, chemotherapy is a blunt-edged tool. It kills a lot of cells. It often misses the cells it ought to really kill, which are the leukemic stem cells. And those often are the drivers of relapse that happen eventually. So as scientists, and this is where I think the field is heading, and the questions that are arising about where the focus should be. Should we be using blunt-edged tools like chemotherapy? And I think that's the answer is no. We should be trying to find things that are more unique to the leukemic cells so that we can kill them. But a further question arises: should we be focusing on eliminating all the cancer cells? Or could we instead help them function more normally? And our work with azacitidine is starting to give hints on, you don't have to kill all of these cells. You just need to help them do their original intended function, which is produce blood more efficiently. And that can avoid a lot of the sort of side effects that are associated with traditional therapy. And of course, the sort of holy grail of a lot of what we want to do is, can we identify specific vulnerabilities that exist only in leukemic cells and not in healthy hematopoietic stem cells or other blood cells? Therefore, we can eliminate these and spare the healthy cells, and so that they can continue creating blood and doing all the things that they ought to do in a person. We're not there yet, but those are the things that I think as a field we're moving towards, and hopefully the treatments of tomorrow that emerge from some of these research directions will lead to more effective treatments that are tolerated better by patients, and leading to better quality of life as well. So without any further ado, I would like to thank the large number of individuals who've contributed to this. This is my lab at our last social gathering before the carnage of COVID. And we are based at the Lowy Cancer Centre at the University of New South Wales, and we work with a wide variety of collaborators, clinicians, hospitals, and hematologists in Australia and worldwide. And a lot of the work and the discoveries that we've made would not have been possible without the sort of contributions that patients on clinical trials have made in offering bone marrow aspirates and blood collections before treatment and over the course of treatment. And it's amazing to me that amidst all of the other things that individuals have to deal with after their cancer diagnosis and then with their treatment, they have still stepped up to the plate and have enabled us to do the discoveries that will hopefully improve the treatments of tomorrow for the whole new generation of individuals. And the work we do isn't cheap, and I'm indebted to the funding that we get from a wide variety of sources, from the Australian government, the Leukaemia Foundation, as well as industry as well. So with that, I would like to, I think I'll end it here, and I'll resume, I'll stop the screen share as well.
Thank you very much, Ashwin. I think that's really great. Some very complex sort of science talk there that you managed to simplify, I think, for those of us who aren't in the level of thinking that you're at. So that's great. And I think people probably find it very reassuring to understand that there are trials going on and that there are people like yourself who are, thinking about things differently and trying to find answers that will help. So
and I should just add, it is a close partnership. So left alone, scientists tend to sit in their little bubbles, disconnected from the rest of the world. But it's a fruitful partnership with clinicians and clinician scientists like Melita and colleagues across Australia who really shape our thinking as well and help us to do
team
effective
effort,
science.
I think. Lots of people trying to do their best. All right, I'd like to hand over to Jane, who's going to run our question and answers segment.
Thank you, Linda. And I think Ashwin, we'll start with you because the focus is on the clinical research in most people's minds, I would imagine, at the moment. And, what I loved was that you said that the patients are the most important component in this, because without their participation, you wouldn't be able to do your research. And a lot of people come to us and ask us, where do we go? How do we find out about clinical trials that are available to them? And, where do they search for that? And I know that that sometimes has a lot to do with their clinician, but we look after people Australia-wide, and quite often people say they're willing to travel to go to other states. So what would you suggest would be, a good search pattern for people?
Yeah, so there are obviously clinical trial registries that do register the clinical trials. But I think, yeah, you're right. I mean, a lot of times the better connected a hematologist is to ongoing clinic research activities, the better they're able to point individuals to that. I would volunteer myself. I'd be happy to be contacted by individuals if they're interested, and I can put them. I'm not a clinician myself, but I can put them in touch with individuals who run clinical trials and are active in that space. But just as the Australia ALLG, is an Australian sort of Australia-wide society that is also coordinating a lot of these activities. So I think there are various, and I should say Melita as well. Raise your hand.
I was just going to add that the registries are, patients can search the registries as well. So there's clinicaltrials.gov that you mentioned, which is an international one, but you can search for Australia. There's also an Australian registry, which is ANZCTR, so the Australian New Zealand Clinical Trial Registry.org. Often Leukaemia Foundation will know what's happening, and through your newsletters, you will often publicise things. And there is, through Cancer Council, they often have search functions, and ALLG does cooperative group ones. So there's lots of places to go to, but reaching out to some of the doctors in your state that might know what trials are around, at least in your state, or put you in touch with other places that will know. I often get emails from people saying what's available for this or that, and we have sort of ways to sort of try and match trials to patients, if that makes sense.
Thank you. I think, with your research, Ashwin, you were talking about targeting the specific vulnerabilities within the cancer cells. And, people are always asking, we looked back 20 years to, your uncle, and then most people are saying, what is nearly close to being used? Where do we see the management of MDS within the next 20 years?
Yeah, certainly. I think there'll be a move away from sort of blunt-edged chemotherapy that just non-discriminately kills everything, towards targeting and tailoring treatments specific to the genetic vulnerabilities that an individual's tumor has. And, so there would be customized treatments based on the particular sort of mutations and things like that an individual has, and those presumably would also, in the hope is in 20 years at least, be more effective at eliminating or maintaining sort of a disease-free state for individuals compared to chemotherapy. And Melita, would you agree with that? Or?
Yeah, so we've worked for, azacitidine was not available when I started 20 years ago, and it was registered and we got very excited, and it was great to have a drug for MDS. But that study that I presented is over 10 years ago now. And I'd have to say that there's been a lot of science going on, but we haven't had any new drugs registered in the last 10 years, which is a little disappointing. The ones that are most exciting at the moment are definitely targeted therapies, as Ashwin said. We worked a lot through ALLG doing combinations of azacitidine with thalidomide and lenalidomide. And a number of Australian patients participated, which was amazing. And unfortunately, it didn't show any benefit. But we did learn a lot about how the bone marrow works, because patients participated and we took samples of the bone marrow. We were able to do some science, and that then gives us leads into the next round of what we might do. So the magrolimab, I think there's some exciting things coming through that are being tested at the moment. I think probably magrolimab in the sort of high risk is probably the most exciting right now. And there are, we're on the verge of a few. So I think, it's been quiet for 10 years. I think we're on the verge of a few new things coming through in the next little while.
If I was to be an optimist and say in 20 years, there's a lot of buzz at the moment of trying to harness an individual's own immune system to try and clear the cancer cells of that individual. In some instances, it has worked a lot more spectacularly than in others. Across the board, it hasn't worked as effectively in hematological cancers as it has in some of the solid tumors, but I think we're starting to understand why that is so. And potentially, if we can overcome some of these hurdles, that might be an exciting potential treatment that might be open to individuals in 20 years from today. Looking at these timescales, obviously it may not make a huge difference to an individual today, but hopefully we're on the right track.
Thank you. I guess, for many people, their MDS is managed with supportive care. And I guess there's a lot of questions about, are there any palliative care trials that are looking at the quality of life for MDS patients?
So I can take that one. There's nothing specific around palliative care, but I guess it depends on what you call palliative care. Palliative care is a term that most people connect with end-of-life care, and it certainly has end-of-life care for people as a component, but palliative care, as you mentioned, is also about managing people with an incurable disease. And so MDS has an incurable disease. It's not inappropriate for people to explore palliative care either from their diagnosis or during their journey with MDS. So it doesn't mean if people are on palliative care that they can't have active treatment as well. Those things can run in parallel. And often I'll have people that need palliative care to help with symptom management, for instance. We dip in and out a little bit. So I don't think people should be frightened of palliative care. I think they're there to support quality of life. So in terms of trials, I mentioned the REDS trials. So they're sort of collaborations. There was a pilot study looking at how we could transfuse people differently to maybe improve their quality of life. So I think that's the first time really we've done any of this sort of work. It's not very, should I say, it's not very sexy research. It doesn't attract funding because it's not a new drug. So they're really important things to fund and support, because this is all about, it's all about trying to use our resources wisely to improve quality of life for people. So those trials I think are really important. how do we transfuse people? And then the lower risk trials, so for instance, the luspatercept and imetelstat, these are drugs that are all about trying to improve people's red blood cells, improve the hemoglobin to avoid the need for transfusions and all the complications and the inconvenience of having red blood cell transfusions. If we can do that with a simple injection that people could give themselves at home, we think that's a much better thing. So again, we've done very few trials in lower risk MDS until more recently. And I think that's a really important thing, rather than just focusing on the latest and greatest new drug, which is exciting, just really paring it back and thinking about how we can actually improve the quality of life.
Melita, thank you so much for that. I think because, you know, as you said, most people think of palliative care as end of life, and we know as clinicians that it's very much used for 90% of our patients for symptom management. And I guess, you know, the importance that you've mentioned is that it is something that can be used right from diagnosis through to advanced disease to manage that. So I think a lot of people online today would appreciate that explanation. I also know that, you know, in our large country that we have a lot of people in rural and remote areas, and you know, management of those people who don't have a specific haematologist in their area. How does that look like to you? Do you get a lot of referrals from regional areas where patients have to travel to come to you for treatment?
Yeah, I've certainly had referrals over the years. I think there's a few things to say, and MDS treatment can be fairly resource intensive. You know, the need for cross matches and transport of blood and blood transfusions, which need to be at a hospital that can manage that. And, you know, as Christine mentioned, she was on transfusions every week. So that's a massive challenge for someone who might live quite remotely. Azacitidine injections are given for 7 days in a row each month. So for someone who lives regionally or remotely, that's a huge challenge if they can't have that treatment closer to home. So MDS is definitely, I guess the other thing to say is this is a long-term, you know, this is long-term treatment we're talking about, unlike some of my patients with lymphoma, for instance, who might have a defined course of treatment over 3 or 4 months. They'll often move to a bigger centre for that period of time, and then they can go back home. So there are some unique challenges to our MDS patients who live regionally. I think the things that are improving an awareness of MDS and diagnosing MDS. I think the treatments to improve the red blood cells that don't need to be given at a big centre. If we can improve people's red blood cells with injections they can give at home, that makes a massive difference to someone's management and quality of life and interruptions. And I think telehealth has made a huge difference in the way that we see managing people. And whereas we were all quite reluctant to make decisions about people's treatment by seeing someone on a telehealth consultation, I think the last 2 years has shown that in a partnership with a local doctor or a local physician, there should be no reason that regional people shouldn't get the expertise of a haematologist sitting in a major centre. So I think the expertise and the decision-making and the questions and all of those things should be manageable for anyone, you know, locally. And I think some of the challenges of delivering a treatment may be regionally, but I think we can start to overcome some of those things.
I think you're quite right. I think COVID has allowed us to move forward and to help people in remote areas. And I think the important factor, and you did touch on this, was the collaboration and the importance of the GP and using the local resources and looking at ways to get, you know, transfusions or treatments given in remote areas. So thank you for that. I guess a lot of people get to the point where we are now because we're still in the research stage and we don't always have the answers or the treatment for advanced MDS. And I guess a lot of people might be wondering what that would look like and how do we manage it?
So you're asking about the sort of when MDS becomes very difficult to manage.
Yes.
And in advanced stages, and that can be for anyone, that can be for people with higher risk disease who have either had treatment or decided not for treatment, whose bone marrow is really failing and have very low blood counts, for instance. Or it can happen for people that might have lived many years on transfusions, and circumstances bring them to a point that that's a really difficult life to be living with more and more need for transfusions. So, and I guess these are really difficult conversations. At the start, there's hope that things might improve, or there's treatments that you're considering and looking at. But yes, many people with MDS will get to that point in their disease where things are not getting better, or they're getting worse, and they're really struggling along. And they're really important conversations to have with family and haematologists and GPs to constantly look at what the best thing is for that person. So is continuing on injections every month or continuing blood cells, for instance, the best thing for someone? And those decisions can be difficult, but I think that's where palliative care, introducing palliative care early. They're experts in having these discussions, having good discussions with family about quality of life, looking at advanced care plans, which is a big thing now for people to use conversations around their philosophy of what sort of treatment they would like, what sort of quality of life is acceptable, and when maybe these interventions that we're talking about might be more troublesome and more burdensome than what that person may want. So I'd encourage everyone very early to think about advanced care plans, have conversations with families and GPs, and even document some of those things around what their life looks like and what their goals and aspirations are, and also to reflect, as you say, on what would be unacceptable. And we can't fix MDS, so it will often get to that point that we need to have difficult conversations about either stopping blood transfusions or stopping treatment, and really allowing people to go down that more end of life path.
Thank you. I think that, when people are diagnosed with MDS, and we know this with other types of blood cancers, the common questions from people are, what do I need to do? What changes in my lifestyle do I need to make? And I'm just wondering what sort of suggestions or tips you have for people. I know, Christine had touched on it, you've touched on it in your talk, but just looking at the lifestyle and wellbeing strategies that can help manage the symptoms of MDS, and of course in doing so improve their quality of life.
That's a really good question, and I think everyone will have their individual approach to that sort of thing. I think it's important to know that there's no one diet or supplement or exercise program that's going to fix things. And it's really about managing fatigue, and that's one of the most problematic symptoms which impacts on people's quality of life. So we don't know necessarily in the MDS group of people, and that's where some of this research and what I call PROMs, or patient reported outcomes, are so important for us to know from patients what makes a difference. But talking about some of that supportive care. So I would say exercise is likely to be very important to cope with the effects of anemia, the fatigue. And I know that sounds counterintuitive if you're feeling flat and fatigued and it's tough to say get out and exercise. And I don't mean, huge exercise programs, but doing something within someone's own abilities and designing something that suits them, about some walks and getting out and about. It releases lots of good endorphins, keeping them fairly, as fit and healthy as we can be. So I think, some exercise, a healthy balanced diet without any specific supplements that I can give you, avoiding smoking and drinking, which are really important things, and really looking after the psychological aspects. So reaching out, asking for help, and there's all those sort of emotional and spiritual domains that I think we traditionally probably haven't addressed very well, but certainly in cancer care and in MDS, that's becoming much more important.
And I think it is very important that it's individualised, because everyone has different needs. And I think you've touched on lots of different aspects in everyone's life. Some might be important to some and not to others. So, but allowing them the opportunity to ask those questions and being referred back to, you know, their GP for support, to the Leukaemia Foundation staff for ongoing support, clinical psychologists. Having that lovely holistic approach, I really think is quite important. I guess, you know, listening to Christine's story, and we do occasionally, or sometimes quite often, hear this, you know, the challenges around actually getting a diagnosis for patients. And quite often people will say, you know, eventually I had a blood test or a bone marrow biopsy, but if I look back on my life, I'd probably been feeling unwell for several years. What sort of tips do you have for people around managing that aspect of where they're, you know, I guess a lot of people look back to say, if I'd been diagnosed earlier, would that have made a difference?
That is really, you know, and certainly in Christine's experience, you know, we heard that she was unwell for a period of time, and at a young age, you know, the symptoms are a bit non-specific. The symptoms aren't, you know, crushing chest pain that leads us to see a cardiologist, for instance. So often it's fairly broad and non-specific symptoms that can make people feel generally unwell. So I think really pushing and advocating, if you know that there's something wrong or you're not feeling well, seeing your GP and having some simple, you know, simple blood tests in the first instance, going back if there's no solution. Christine and I have worked together on what the Leukaemia Foundation have been developing, optimal care pathways, which is all about empowering the GPs as well to recognise some of the symptoms, learning what to test for, how to make that diagnosis, and referring people off. I would say that in the vast majority of cases, knowing about it sooner almost certainly doesn't change things, or it's not that you miss the boat with something. The people that we talk about treatments in the high risk group, things declare themselves, and it's quite natural for that to be some weeks or months before we sort of pick things up. So, you know, you don't miss the boat with things most of the time if it's taken some time to make a diagnosis, but I'd certainly advocate, you know, a simple blood test can often pick up little clues in MDS.
Thank you. And I guess one of the things that we perhaps get asked a lot from our patients is, you know, can they be a part of the decision making? You know, historically, we have been brought up in the past, and, you know, the age group of patients predominantly with MDS is that they listen to the advice of their doctor and they accept it and they don't question it. What would be your, you know, advice around this for patients?
Absolutely. So it comes back to that individualised care and advocating, having family and friends involved. I think, and it's a bit of a style with doctors, of course. So some doctors are a bit more definitive about treatment pathways, but, you know, this is, and I say to patients, this is your health, this is not my health. So this is empowering yourself with information, going armed with questions. What about this? What about this? Why do you think this? And talking about the options. And even if I have a reasonably strong feel for what might be the best process or journey for someone or pathway for MDS, I'll always present ends of the spectrum. You know, some people might go for this, some people might go for that. So, you know, when it's your health at stake, you should absolutely be challenging your doctors and say, why this or why not that? And they should be able to provide some sort of context or information as to why they felt that one treatment or another might be better for you in your individual circumstance. And I guess we have to be careful not to compare ourselves to other patients with MDS, because it is a disease that's very different for different people, and everyone has their own wishes. Everyone has their own other medical problems that can play a part in that decision making. So, but that's where you need to get your pathway right with your doctor about why those decisions are being made. And I think Leukaemia Foundation does that very well in providing information and ensuring that you've got someone else there to ask questions and advocate for you.
And I think that's quite true, because people might often think that a simple question is not worth asking, and yet that's the most important thing on their mind at the time. So thank you.
Sorry, JD, can I just invite Christine if you want to comment about any of these questions as well, as someone who's experienced it firsthand, if you wanted to just add anything to what Melita has said or Jane has commented on.
Yeah, I think Melita has really summed up a lot of things really well. I know that when I was diagnosed, I didn't go down the path of saying, okay, what diet do I need to go on or whatever. I decided to just make sure I had a healthy lifestyle, healthy diet, tried to stay active as much as possible. I started working with an exercise physiologist, just so that whenever I had any treatments, and I didn't have anything apart from the daily aspirin, I didn't have it as a dietitian or anything like that. But if there was any possibilities, that I was as well as I possibly could be. And I think Melita is she's mentioned it a couple of times that everybody is different. You know, no two people with MDS has the same symptoms or treatments, and I know that firsthand. My brother and I both have MDS, MPN, RAS-T. We were diagnosed three months apart, a couple of months apart, and our treatments, whilst being similar, have been very different. And it has to be personalised. And we had the same haematologist taking us through it. So yeah, it is very much a personal journey, so to speak.
Thanks, Christine. You know, I think it's always good to hear the patient's perspective as well. Now, we're getting close to time, so I'll just ask one last question, and this has come from someone who's online. And are there any known causes or factors that, you know, predispose people to getting MDS?
I think Christine's story with a sort of a hereditary nature is definitely the exception rather than the rule. And we would generally say that this is not a hereditary disease, even though we've talked a lot about genes and gene faults. We're talking about faults that develop in bone marrow, not that you're born with or you pass on through families. We don't really know what causes MDS. We know that, and as you saw the graph, it's definitely a higher, you know, rate, you know, and really in people's 70s and 80s. So it's the biggest risk is age. The things that we know that may increase the risk of MDS are things that can be toxic to your DNA. So there are some chemicals, benzenes typically, paint thinners, and we see some people who have had either chemotherapy or radiotherapy to areas of bone marrow before for other cancers who are at higher risk of MDS or AML. So they would be really the only things that we would say we could sometimes connect the dots, but there's no lifestyle, it's not smoking, alcohol, hereditary things, power lines that we've been able to establish.
Thank you, that's made it very clear. I'll hand over to you, Linda. Thank you.
Okay, so there's been quite a lot of information today. It's been a long webinar, and we like to wrap up generally with just asking our guest speakers if they could just give us one key message that they think is important for the audience to take away. So Christine, we'll start with you quickly, but you just you know, you talked a lot about the individuality of the disease and the exercise and, you know, living well. Is there anything you'd like to add to that? Anything specific that you think is most important?
You know your body better than even your doctor. So if you're not feeling right, keep asking questions. That's the thing that I'm thinking. And if you don't feel comfortable, I always took my husband or my daughter into my appointments, so they could ask questions on my behalf. And sometimes the doctors, when they answer questions, do it very scientifically. So if you're not sure, if you don't understand, keep asking and ask the same questions hundreds of times if you need to. So yeah, that's what I'd say.
Beautifully put. Thank you. What about you, Melita? What would you like to share?
Look, I think I've said it lots of times, and I think just you're an individual, and this is your own pathway. So it's very hard to compare. Definitely reach out and find out about lots of different people's experience, because you'll get bits and pieces from everyone. But you and your doctor and your family have got to work out what's right for you. So, but I agree, keep asking questions.
Thank you. And Ashwin?
I would say that research is important. We know more today than we did 20 years ago. That has led to improved treatments, but there's still a long way to go. But research is exponential as well. So we build upon the knowledge, and creating that knowledge requires a true partnership between people like me, scientists, clinicians, but most importantly, the people who are suffering from the disease, unfortunately, but contributing towards knowledge that will improve the future.
Thank you so much. All right, so that draws our webinar to a close. I'd like to take the opportunity to thank firstly the supporters of the Leukaemia Foundation. Without them, we wouldn't be able to deliver education events such as this for you. Our guest speakers, Christine Heath, Associate Professor Melita Kenealy, and Dr. Ashwin Unnikrishnan. We thank you generously for sharing your knowledge, expertise, and time in participating. And lastly, and most importantly, we thank you, the people living with the blood cancers, you with MDS, who have joined with us today. We encourage you to take the information you have heard to further the conversations you have with your healthcare teams, your family, and your friends, and help guide your treatment decision-making.